Good evening, everyone. My name is Inakshi Sopti, and I'm the Chief Executive Officer of the Asia Society India Center. I'm delighted to see members, patrons, and friends from across the world join us this evening. For those of you who are joining us for the first time, welcome. The Asia Society is a leading educational organization dedicated to building awareness about policy, business, education, and arts from across Asia on a global stage. Through our 13 global centers across Asia, Europe, and the US, we stay committed to sharing contemporary studies, highlighting emerging trends, and spotlighting innovative solutions with a view to deepen understanding and engagement between Asia and the rest of the world. We're very pleased to be working with Dalberg on this program and discussing a very crucial piece of research authored by them. Their recent study, Impact of COVID-19 on Women in Low-Income Households in India, highlights some alarming trends with respect to women's employment, their health, and the disproportionate impact of the pandemic on their emotional well-being. Our discussion today will spotlight the areas the report studies, delves into possible solutions, and find answers to relevant questions. What are the burdens of care work and unpaid labor on women and the economy? How can national social relief measures help to put women back into the labor force? How has nourishment and reproductive health of women been impacted in this pandemic? We have the honor of hosting an expert panel to discuss today's subject. Please allow me to introduce our esteemed speakers. Due to a medical emergency, Sweta Totapalli from Dalberg will not be able to join us for the program. However, Vineet Bhandari, associate partner and co-author from the team, will be replacing her as part of today's panel. Vineet Bhandari is an associate partner at Dalberg Advisors. His experience spans a wide range of areas, including digital agriculture, digital financial inclusion, and urban development. He also leads a number of integrated strategy and human-centered design projects. Sapna Desai is an associate at the Population Council in New Delhi. Her work focuses on women's health and well-being in India, particularly community-based interventions, health systems, and sexual and reproductive health. She co-leads the Global Evidence Consortium on women's groups, as well as the Council's internal initiative on infertility. I'm also delighted to state that Sapna is an alumnus of our Asia 21 Young Leaders Community batch of 2012. Divya Nair is director at ID Insight and has led learning partnerships in agriculture, financial inclusion, sanitation, and nutrition. Currently, Divya is leading ID Insight's COVID response team in India and is engaged on a variety of innovative and impactful projects with key government and non-government partners in India. Sohani Jalota, our moderator this evening, also an Asia 21 Young Leader 2019, is the founder and CEO of Maina Mahila Foundation based in Mumbai. Her mission is to bring equal access to healthcare services for all. She's been working on urban slum areas and rural communities, researching and designing strategies on projects ranging from adolescent girl health, water and sanitation to social protection policies. A bit of housekeeping before we proceed. All those who are joining us on Zoom, please leave your questions in the Q&A box. And for our audiences on Facebook, please drop them in the comments section. I'd now like to invite Sohani to commence the discussion.
Thank you so much, Inakshi, and thank you for having me here, Asia Society, to talk about such an important topic about engendering inclusion, reflecting on women's health, employment, and hygiene. And welcome to our fantastic panelists, who I'm so excited to learn more from, Vineet, Dr. Divya, and Sapna. Today. Divya, actually, we've worked together at ID Insight before when I was there. It's really great to have all of you here today to discuss women's health and employment. I have spent the last decade working with urban slum communities and urban slum residents on women's health through the Meena Mahila Foundation, which is focused on women's sexual and reproductive health. And over time, we kept hearing again and again about how women did not have the means to buy medicines or take care of their own health. And oftentimes they compromised on their health for dignity purposes. And even after being educated, women were just not taking up jobs or were not able to take up jobs. In the last few years, as part of my PhD thesis and through Meena Mahila Foundation, we've been trying to understand the constraints to women seeking healthcare, but also for women labor force participation, and testing out some solutions that could potentially work for them, and how health and employment can go hand in hand. This has been looked at by many of us, and I think Dalberg has done an excellent service to this country and to the country's women today by highlighting some of the challenges that women are still experiencing, which have been worsened with COVID-19. COVID has really had far-reaching consequences for everyone, particularly for women. And it's really served as this reality check for us now, that we see women that are experiencing higher rates of domestic abuse, poorer access to sexual and reproductive health services and mental health, to financial instability and lack of access to just any sort of healthcare amenities. The virus has really been severely detrimental to women across different countries. Particularly when we're looking at the poor populations, so women in urban slums, they're more vulnerable to COVID-19 because of the precarious nature of employment of women informal workers, as they tend to work in these very risky, hazardous, and stigmatized jobs, sometimes as frontline workers, as waste pickers, as domestic workers, who have really been left jobless around this time. We do know little still about the effects of the pandemic on women in slums, or we knew little, I think, before we had some of the reports that have recently come in, I think, from Dalberg and also some work done by ID Insight. At Mena Mahila Foundation locally, we've conducted a small survey with about 2,000 women to understand their perceptions around COVID, the livelihood effects, stigma, and health. And we found that around this time of the study, which was around mid-2020, around 90% of the women were actually unemployed, and 98% of them had some sort of an effect in their family because of COVID on their livelihood status. Dalberg has done this study now with more than 15,000 women and 2,300 men across 10 states in India, and we'll discuss more of these details today. COVID has not only taken us further behind in our progress, but has also made us realize that the progress that we've made could actually be easily reversed. That is, our systems and norms were not resilient enough. To progress sustainably and to be able to face calamities like COVID again, or effects of climate change in the future, we need to build systems that can really stay, that can weather the storm. So in today's event, we'll discuss the report that Dalberg has released. And we'll start right here first with Vineet, who's co-authored this report. Vineet, if we start first to just talk about the broad questions, the big questions that the Dalberg study really asks, and how did you decide to select these questions for the study?
Thanks, Suhani. And I think before I answer your question, thank you so much for that introduction. I'm very excited to be sharing our findings with this esteemed panel. I think just when I reflect back on the journey we've had when we started out, I think when the first lockdown hit the country, there was a bunch of research that was conducted by multiple private, public, as well as social sector organizations about the effects of the pandemic. There was a lot of conversation around migrant workers and many other communities. But back then, what we felt was that large-scale data focused on how the pandemic was specifically affecting women was limited. So that was our motivation. And then we said that let's actually design this study to be potentially one of the largest studies on socioeconomic impacts of COVID-19 on women. As you said, we covered about 15,000 women and also wanted to do a dipstick around of 2,300 men, specifically on the impact of COVID on women from low-income households, given that we knew that the impact is potentially going to be harsher on that community. At that point in time, I think there was so much unknown about this. We wanted to cover many aspects. So we studied livelihoods, we studied access to essentials, we studied impact on assets and debt, food and nutrition, sanitation, and time use. And I would say there were still areas that we couldn't cover, primarily because of sort of just space and constraints around phone surveys, for example, gender-based violence, mental health, access to healthcare services. There were some segments that we weren't able to cover, for example, girls below the age of 18, pregnant and lactating women, some hard to reach populations such as women without phones and so on and so forth. So I think we wanted to, by intention, we wanted the study to be wide and broad and touch upon a number of different aspects. And hence we focused on, like I said, the socioeconomic impacts. And secondly, I think what we wanted to do was also take a focus lens on how can actually government programs, right, reach and help mitigate the negative effects of the pandemic. So we did look at reach and effectiveness of government schemes such as PDS, Manrega, self-help groups, and so on and so forth. And then lastly, I think the big question for us, which you rightly said, was like, what were some opportunities to mitigate and potentially even reverse the negative effects of the COVID-19 pandemic on women, right? So I think those were the three big questions for us as we went about doing this work.
And were there any findings that were surprising to you during the course of the study?
Yeah, I think I would say a large part of what we did, what we found was definitely a hypothesis that we had, but I think the extent of the impact on women was definitely surprising. So, for instance, even on economic impacts, right? We figured that women made up just 24% of those working pre-pandemic, given our low labor force participation, but yet they accounted almost 28% of all those who lost jobs, and almost 43% of people who yet to recover paid work, right? So they were hit harder and were slower to recover, right? So the extent of sort of the impact on them was actually fairly high. The other bit that was, again, on the extent that was surprising for us was that far more men actually reported an increase in rest than compared to women, which is, again, definitely almost, I would say, about 1.5 times more men actually said they had far higher rest times during the day as opposed to women. Is definitely very surprising in terms of the health. And I think there were definitely some things that were unexpected. We knew that the government schemes, for instance, definitely covered a large fraction of women and population in the country, are an important lifeline. But again, I think the fact that a lot of women said that government welfare schemes and self-help groups were actually very important in helping them navigate the pandemic. Almost a third of them said that they equated support that they received from these communities as well as government programs to be almost as important as their families, right? Was actually very surprising. Manrega, for instance, was particularly beneficial. SFGs were particularly beneficial as a borrowing channel. PDS was almost 70-80% said that women said that that was a primary channel to access food and nutrition during these times. So I think the effect that of these government programs on women in low-income families was definitely. We knew it was important, but the extent to this was important was definitely new to us.
Right, and Vineet, was this observed, the stress and the importance placed on government welfare programs both in rural areas and in urban slums for low-income communities, or mainly a rural phenomena that you observed?
I think it. I would say in general, I think it. We saw that government lifelines and government sort of entitlements were important both in urban and rural areas. Naturally, because some of the schemes are more targeted at the rural areas, for example, NREGA, right, as well as SHG networks, like the extent of support that women experience there is far higher. But in general, I would say both urban as well as rural women said that the government, that the support they received from government entitlements was very important.
That's quite interesting. And Divya, I believe that ID Insights also done some similar work with multiple surveys around COVID and its effects on women. Do you want to shed some insights from that might be similar or different from the Dalberg report?
Sure. Hi, Suhani, and it's a pleasure to be here. So I can just start with a little bit of a description of what ID Insight did in the same time period. Is between April and November, we also conducted around 8 household phone surveys. And our focus was all on rural India. So that was, one distinction. And the last survey that we conducted, which was in November, around almost the same time as the Dalberg study, was focused on looking at gendered effects of COVID. So what we did was we were looking at both men and women within the same household. And we, kind of tried to get a sense of, what the differential experience was of in many cases, husbands and wives. And it was very interesting. Just to first, give you a little bit of background about the other surveys, is all of those were conducted rapidly. They were often done, in close conjunction with government organizations. And, the idea was to kind of be responsive and get a sense of often the relief efforts. So over time, the interesting thing also was getting a sense of the dynamic or the dynamism in terms of relief efforts. Because by November, we saw that things had really, in many cases, improved. But then we also saw that they hadn't often gotten back to pre-COVID times. Like tracking over time kind of gave us that sense of a trend, which was also kind of helpful. The first thing I'd say is that, our results are very similar to the Dalberg study. And that was, it really kind of is heartening to see. And it also, it's kind of nice when different organizations kind of, collectively are saying the same thing. And hopefully it can be used by a range of, audiences. And especially when, like government official data is often not available. Hopefully, officials also feel more confident in terms of using some of this data, because we're all kind of saying the same thing. And so I'll just highlight a couple of key areas where, which really resonated from the Dalberg study. One, in terms of male-female differences, is food security. Basically, as I said, we're looking at men and women within the same household. And we found a 10 percentage point difference in terms of women reporting higher food insecurity. So 58% of women reported food insecurity, like one sign of food insecurity. And I think we used the same questions also. We had coordinated with the Dalberg team. And so that was really, disturbing. And this was, as I said, when situation had improved by November. The other piece was in terms of, even though, such high food insecurity was being reported, what was heartening was we saw a huge uptake of PDS, and 90% of households were reporting that they had access to PDS. And so that was really great. And, what we had seen early, for example, in April, the numbers were very low, and the government was very quickly able to kind of increase coverage of PDS. We also saw that compared to PDS, again, like the Dalberg study finds, Manrega was less accessible. And in fact, what was interesting was that Manrega had reduced the number of days that were available for people who applied to work on Manrega, reduced by November as compared to some earlier surveys that we conducted. And finally, kind of making a segue to Sapna's conversation, is we did find in our surveys that being a member of self-help groups for women was very helpful. 30% of the women that we interviewed were members of self-help groups, and it was a bit of a peculiar survey, the one that I'm referring to, where 30% is I think on the higher end. But what we found were two things that I can mention is those women who were members of self-help groups were poorer to begin with. So it'll be interesting to hear if that resonates with Sapna and Vineet. But we also found that they were able to access Manrega at a higher rate. So, they were able to access some of these public services better. And so that, gives us hope in the sense that basically it's an enabler. Being this membership, it gives them a sense of how to kind of they have a sense of what the process looks like, what the access issues are, and they're able to kind of maneuver their way collectively. I'll stop there.
Thanks so much, Divya. And Sapna, really picking up from there, can you maybe for the audience also elaborate how the self-help group system really works and why it could be beneficial for women in a scenario like COVID?
Well, first of all, thanks so much for having me here, and it's great to be with Asia Society again and with colleagues and friends here. So I'd like to thank Dalberg, of course, first for the report. It's so important to see a report that looked at health, but also the social determinants that underpin health outcomes as we know them, like employment, labor force participation, and things like membership in self-help groups. So for the audience, self-help groups, or the SHG program as we know it today through the National Rural Livelihoods Mission, is definitely the largest program in the world of organized groups of women that are typically about 10 to 12 women who come together with a primary focus to save together and to basically engage in financial programs first, so microfinance as we know it. But the program has expanded incredibly across the country in two ways. One, in terms of its breadth, in terms of the number of households covered. You see certain states like Bihar with incredibly high coverage of lower income women. I can't remember the last number I've seen, but it's certainly upwards of 60 to 70%. In other states less, but in addition to the breadth, what's been really important about the self-help program in the country is the depth of programming that it has been able to incorporate. So starting from a microfinance program where women get together weekly, contribute savings, and then are able to jointly save and take loans, it's expanded to really focus on livelihoods through training, to work on health, food, health, nutrition, and hygiene as well, and WASH, as well as address gender issues. And this has really varied, like all national programs, to be honest, has varied immensely state to state. And the state rural livelihoods missions have, addressed needs locally in different ways. And it's important to remember that when we even think about these findings, that a lot of this is dependent on the state that we're talking about and the diversity we've seen, not just in how people responded, but also in terms of the lockdowns and the response at the state level. So coming back to what Divya started with SHGs, the Evidence Consortium on Women's Groups that I work with, we did take sort of this burgeoning area of research on SHGs that emerged right after the lockdowns, a lot done, of course, by Divya and Vineet, as well as looking at the National Rural Livelihoods Program itself, its MIS, its Management Information System that tracked loans and mobilization. We also looked at globally what has been the historic response of groups like these to shocks and to economic shocks, and what has been the sort of resilience that these sort of groups have contributed to. And we found both here, as well as in other settings, that these groups certainly contribute to resilience, probably at that immediate response level too, in terms of diverting savings towards consumption, for example, which we certainly saw. But we also see that, of course, money that's mobilized decreases over time because women cannot meet. And particularly during the first lockdown, groups couldn't meet because of social distancing, etc. There were initial restrictions and then they were eased. And again, groups found interesting and innovative ways to meet, on the phone. You had the facilitators or the mobilizers still in touch with women. And it's important to remember these women live in the same areas. They meet weekly, they know each other. There's a degree of social cohesion or capital that's already built underneath or on top of, I would say, the financial component. So we found that there was that aspect, the resilience, that short term, but there's also that idea that women had somewhere to go and somewhere to turn to, an existing network. And this came out through a lot of the qualitative research that was done in the country in terms of different responses SHGs came up with to partner in the response that ASHA workers were already leading with health, as well as things like addressing violence against women. But that said, we also saw huge diversity across, again, states in terms of how resilient that platform was, how women were able to mobilize savings, for example, and also the amount of loans that they were able to access and needed varied state to state based on existing programs like the vulnerability reduction funds. And to Divya's point, I think it's really important that, yes, our analyses show these from other settings too, the convergence that SHGs sort of facilitate through programs like rural employment is incredibly important because it allows women access either through awareness or through actual mechanisms to access benefits. So I think SHG members probably benefited that way in a way that's difficult to capture, but you do see that they just have a savvier sense of perhaps dealing with public services. One thing that I'd like to just flag is that what we don't know, and I think we'll all keep studying, is what is the effect on the long-term resilience and sustainability. What we've seen in other settings is there's that immediate short-term response to a shock, like the lockdown, where the SHGs or women's groups are really important, but how do they contribute to the long-term resilience if the groups themselves are suffering because some of the savings are diverted towards consumption? And I think that's the question that we need to keep tracking and following through surveys like these, as well as just tracking administrative data.
Right. And Sapna, if just talking more about the ASHA workers that you mentioned and women in self-help groups, are they serving any sort of purpose, you think, for the broader community in terms of serving as, say, role models, or other people now also are in some ways? Because this is sort of creating this sort of longer-term resilient system by having such self-help groups for people across in the community as well, and for community health workers as well, really, who were the faces of COVID. Did that create any sort of gender norm changes in the community and also serve as role models for the rest of the community? Did you see any of that?
I think, again, coming from work I've been tracking with SEWA, with the Self-Employed Women's Association, at least looking at health workers and the importance of local health workers. So that's the ASHA, of course, as well as a lot of the NGOs across the country that obviously spurred into action very quickly with their local community health workers and programs. That was absolutely key. I mean, what SEWA saw, for example, across the 10 states it was working in, is that having a local health worker who was already there in the community was absolutely critical at a time where people could not meet. She already had the access either telephonically or could go house to house with that trust. And she was critical to helping women access services, pensions, etc., when everything else was really difficult to access. To your question around norm change, I think it's an interesting one because, look, the ASHA workers undoubtedly were at the forefront of the health response to COVID. And I mean, everyone saw it, it was all over the media, you've seen the reports, the studies, but did they get their due, I think is another question. And were they treated the way, I mean, the program itself, community health workers are at the backbone of any public health system, and ours as well. But, you know, the due that they deserved, both in terms of course, financial incentives, but also the support, I think remains a question. And we saw great examples in some states. So it's important, I think, to learn across states to see how to do that better. So I think the social norm change will come when you see community health workers, women health workers treated on par with the services that they provide.
Yeah, and Swani, if I may just add to that, I think this point around ASHA workers, I think being at the forefront is something that we also witness. I think to be fully transparent, we didn't sort of we weren't able to cover a lot of ASHA workers in our survey, but we also did a bunch of qualitative work. And I think through them, we heard the same thing. But I think the other bit that I think was a bit of worrying for us is we know that they were already stressed and the system was, I think, pushed to its boundaries. But at the same time, there's a new kind of stigma also attached to this, right? There was a lot earlier, we heard one ASHA worker, for instance, said there used to be a lot of respect for ASHAs. Now they don't even let us enter the houses, right? Because like they drive us away, they will not tell us the symptoms truthfully. Like they are scared, we'll report them. Some feel that if we report, they will get more money and so on and so forth. So I think this point on is that actually changing sort of norms, I think is definitely an interesting one. But my sense is that the systems is already fairly stressed, and COVID actually pushed that to the boundary as well.
That's very interesting. It's working both ways. So it could be beneficial or it really could be detrimental, and we really don't know which way it's gone. Probably, and to Sapna's point about it really differs by state is quite important as well, where the traditional norms and culture could also be contributing towards this. Divya, you were raising your hand. You want to add to this as well?
Yeah, I just wanted to kind of bolster the point here that, we've also done some work on social and behavior change communication. And basically what we have found is the importance of getting messages from ASHAs and Anganwadi workers to, a range of beneficiaries, especially, for example, pregnant and lactating women on nutrition messages. So, the most powerful way of like getting a message that is then internalized and then potentially acted upon is from a person who you trust, you see regularly in the community. And we've done these large surveys where we looked at, basically the government has 21 different platforms through which they provide nutrition messages to pregnant and lactating women, and the most powerful are the ones that are interpersonal. Of course, in the context of COVID, interpersonal communication is hard. So there's been a lot of innovation in this space in terms of, how to still be able to provide this messaging through WhatsApp groups, etc. But still, that point of having trust in who the message is coming from is important. And so I think the power of these women is something that I think we've all appreciated for long, and especially during COVID, it's become stronger. And I think there is this kind of now movement, hopefully, to really get these women their due, because as Sapna was saying, they just have been under-resourced and under-supported.
Yeah, been too long on the honorariums. Yeah, totally agree. And this concept of the stigma that exists around this as well, even if somebody is trusted, I think, but somehow during this time, we've lost trust in a lot of people we used to normally trust in the communities. We've seen that happen even in urban slums, and that became very apparent with the vaccination take-up as well, which was so low because people just didn't trust the same health providers to get the vaccinations because they just felt that something was wrong. And we've seen that similar sort of stigma against menstrual health, women's reproductive health overall. So really talking about the impact of the pandemic on women's already stigmatized topics that probably became even more hidden and even more invisible around this time. I know that probably Divya, Vineet, Sapna, you all have something to share here about just what you think is the impact been on women's sexual and reproductive health access and outcomes as well, looking at product usage and or other challenges that women have experienced around this time. And if you want to share any of the findings and or insights from your surveys.
I can go first. I think we, amongst health and nutrition, I think we looked at three components largely: food intake restrictions and food insecurity, which Divya has already talked about, and our results were fairly similar, so I'll refrain from sharing. I think the two other areas that we looked at was menstrual supplies as well as sort of reproductive supplies. And I think what we found was that dipping incomes also restricted women's access to menstrual and reproductive supplies, right? So we found that almost 16% of respondents who previously had access to menstrual products experienced limited or no access between March and November 2020, and that's fairly significant. Similarly, when we looked at married women specifically, we looked at about more than 1 in 3 married women were unable to access contraceptives, either because they couldn't afford it or because of safety concerns about visiting, say, for example, primary healthcare centers. So I think significant majority of significant groups of women, for example, were hard hit both on accessing sanitary napkins and menstrual supplies as well as reproductive supplies. And I think while these are sort of the average numbers, obviously there were subsegments, right? Migrant women from even lower income households within the low income households that we're talking about that were harsher hit, Muslim women, for example. And their impact was, I think, manifold, much more than the average.
Yeah, I think we've actually experienced very similar insights to do with menstrual supplies, where women were just not coming up and talking about them. They also didn't know where to go. Many of the chemist shops also did not have a stock of supplies at this time. And female doctors are just non-existent in a lot of low-income communities. And so if you have any issues now with a lot of stigma around COVID, you can't go to healthcare facilities anymore. So where do you really go? And we did find women just did not have any knowledge of where to really head in. That's why I think some helplines had come up, which were quite helpful. And obviously we've seen rises in domestic violence cases as well, mental health conditions here also becoming worsened. But Divya, Sapna, do you want to add anything here on the menstrual health indicators? Yeah.
Sure, I can jump in. Kind of again, echoing a little bit of what Vineet said is we asked this question of women in rural India, and 44% of women said that they could not access their preferred menstrual health product So this is a very high number. And the reasons included, the top reason was that economic, they didn't have the money to purchase the product that they could pre-COVID or that they preferred. So that was around 28%. And then there were other issues, as you mentioned, Suhani, of mobility, right? Like they couldn't leave the house to purchase it, and maybe, you know, because of stigma, or they couldn't ask someone else to get it for them. They chose not to buy it, and then after that, as you said, one of the reasons was that there was a lack of stock for their preferred product. The other thing is, to me, and Suhani, I know you worked a lot in this space, but it's really like, it would be great to hear from you more in terms of where we are today, in terms of even, you know, pre-COVID, and maybe Sapna can talk about it, is, you know, this is a situation, like, I feel like during COVID, we heard more about it. And maybe, you know, there can be some momentum that can be used now to address this issue, because I feel that the numbers are just so shocking in India. Yeah. And the other thing, we're doing some work in Rajasthan, and one of the platforms for getting sanitary pads to girls and women is schools and Anganwadi workers. And with the closure of these platforms, it made it even harder for them to access. And yeah, I hope that, you know, the government is thinking of now using these platforms more actively as as things open up.
Yeah, all completely resonate with a lot of that. I think in urban areas, accessibility of products is less of an issue than it is in rural areas, just because it's accessible for other types of populations, and low-income populations tend to benefit from that increased accessibility. But I think in terms of the education and awareness around it, anyway, schools were not educating girls about their reproductive health, but their peers used to. And now, with lack of contacts and connections with their networks, I think they became completely isolated. So we've had just numerous cases of girls coming to our centers only because these are the only women centers, only women communities that they can get access to, where they would ask about very basic things like, I'm really worried I've not had my period for 2 months, but I would talk to with my friends, but I don't really know what to do. And these kinds of cases then increase to 10, 15 a day from just having 1 or 2 a week. And so we were really seeing that girls were looking for spaces for information and for health advice. So we then started our telehealth programming around this, because we realized that we needed many more individual personalized attention, I think, given to each of the girls, beyond the product access as well, which I think is definitely an issue, but right now is definitely improved quite a bit in terms of product accessibility. But I think education is still lapsing because schools aren't yet open. Sapna, would you like to share any insights as well here on effects on nutrition as well for women?
Well, I wanted to highlight just the context we're speaking about when we talk about women's sexual and reproductive health in the country, in terms of where the baseline status, where we start. I mean, I looked at the National Family Health Survey 4 when we had the national data, at least, because we don't have all of it yet for the most recent round, excuse me. So for things like reproductive tract infections, treatment seeking is still really low. What we see is prevalence is very high, up to 2/3, and some stated women will report having an ailment, let's say, in the past month, but you have numbers as low as 8% in the Northeast to maybe over half of women reporting seeking treatment, which is still low. And that really speaks to both access issues in terms of, as you rightly said, are there female doctors available, as well as the norms around seeking treatment for reproductive tract infections. So where we began on this was already, there are a lot of barriers to seeking treatment for reproductive tract infections. And then, of course, menstrual hygiene being part of that in terms of women's access to products for themselves. But there's also this whole huge area of gynecological morbidity that is generally, how do you say, I mean, it's not ignored, but it's certainly not addressed to the extent it needs to be. We have a health system completely geared towards maternal and child health, or increasingly with adolescent girls, but in terms of what women face over the life course, particularly post-childbearing years, services at the primary level are very, very limited. So a time like COVID and the lockdown really highlighted that and show that, you need services close to women at the primary level, whether it's a health and wellness center or in the hands of the ASHA. But when it's things outside of contraceptives and things related to pregnancy, which the HMIS, I think we all know that, essential services took a hit in the first round. We know that, but the other services we actually don't know anything about. So the services that women need on a regular basis outside of having children, we actually don't know what kind of hit they took. And as if you go across the life course, particularly older women, what we do know from the National Sample Survey is that it's those women that report the highest rates of morbidity, as well as seeking treatment for a whole range of non-communicable diseases that are, not really been talked about. And the reason I bring it up here in a discussion on COVID and SRH is that if you look at the risk factors also for COVID, we knew it was a lot of chronic disease. So, there's an importance of looking at these in a cycle, thinking about women's health through the life course, but also looking at the links between things like access to services for reproductive health and gynecologic morbidity, and then how things change over a woman's life course. So I think, we didn't start in a great place, and hopefully this highlights the issues we have with ensuring that primary care is, again, responsive. And the point Vineet raised around, or at least the report did, on contraception, I just wanted to highlight that sterilization is the most popular form of, or most used form of contraception. So that in of itself, again, because women weren't accessing facilities, you saw less use, but that in of itself is a problem in terms of access to other methods and longer lasting methods, perhaps. So I think what COVID did in a way is highlight and bring to the fore the importance of ensuring that these services are accessible, close to women, and also in ways that they need at the times they need them. And actually, a lockdown shouldn't have affected that if they were in the hands of community health workers and local primary health centers.
Totally agree, Sapna, on that. And then really, when it comes to family planning related outcomes, Vineet, do you have anything else to add as well in terms of the findings from the report on the accessibility to contraceptive methods, as well as any sort of lapses and accessibility to doctors around this that you'd like to share?
So we weren't able to go as deep as we would have wanted. I think what we were able to figure out, like I said, is about a third of women were unable to access contraceptives overall. But I think PHCs and access to some of these reproductive healthcare services is something we were not able to actually capture as part of the work.
Got it. And when we look at the employment indicators that were devastatingly low, and Vineet, you also mentioned that employment has some detrimental effects on health as well, and job loss. Can we talk a little bit more about employment's effects on health for these women?
Yeah, definitely. I think that's the primary lens that we actually took. And our primary hypothesis was that given that there will be large sort of hits on employment, on women's employment, that would actually have cascading effects on a bunch of other things, right? On their own personal savings, access to, for example, sanitary napkins, access to sort of reproductive care, and so on and so forth, right? And basically what we saw was exactly that, right? So if you look at the numbers, we saw about 60% of women we surveyed had lost their jobs. And by October, a significant majority, about 35%, were yet to meaningfully recover their jobs or incomes, right? So a number of women were back at jobs, but they were still earning less than 50% of what they were earning prior to the pandemic, right? And you have to also remember that the baseline starting income for women was already considerably lower, right? I remember, if I remember the number correctly, it was already just about $6,000 or $7,000 on an average that a woman respondent was earning. And they were earning now less than 50% of that, right? So that's just 2,500, 3,000 rupees a month, right? So significant, I think, economic impact overall. And then I think, again, also important to sort of de-average the picture a little bit, right? If you look at domestic workers, for instance, right? Although they were also significantly impacted by sort of by job loss, 18% of those who were previously employed in domestic work were yet to regain work, right? And that's significantly higher than average, right? Almost the average was 11%, and this what we're looking at is almost double that, right? Similarly, we also looked at women from lower income households were also slower to recover. Casual labor, for instance, recovered jobs, but the income recovery was significantly smaller, right? And then I think to your point around how this impacts sort of health and nutrition, I think I would say the economic impact plus I think the impact on time use, I think those two things put together actually lead to multiple other impacts, right? So I talked about sort of we estimated that almost unpaid work went up almost 3 times for women, for example, within the study, during the first lockdown, and almost 47% of men had at that point, I said that their period of rest had increased as opposed to just about 31% of women, right? So significant change in sort of time use, plus I think significant change in their ability to do paid work and income, I think led to sort of the multifold impact that we saw on health, access to crucial supplies, savings, and so on and so forth.
One would expect that if there is this increase still in period of rest for women or for men, that accessibility or having more time to be able to take care of their health is increasing too. They get more time to sleep. That could improve their other health indicators as well. Was that qualitatively also asked and observed? Why is
in
this
fact, I would say, in fact, we saw the trend other way around. I think I remember one conversation when we were talking to, I think, a casual laborer from Kerala, and she had said that, sure, like I do have more time, but what do I do with that time? As in, my kids are now at home, so I have to do oversight. They can't go to school. And even if there are jobs, my husband can, for example, still go out in the fields and do sewing, but I'm not skilled enough to actually do sewing. So my opportunities are still limited, right? So just the fact that all of these things are sort of coming together and that actually sort of impacts has sort of multifold impacts on all aspects of their lives, which is what we sort of, I think, tried to study, and I think covered a bunch of sort of topics, but I would still say really just scratch the surface on the kind of impacts that all of these effects are having and continue to have on the lives of women.
Divya, you raised your hand as well. Do you want to chip in?
I just wanted to kind of chime in on this, is that we asked about how they were spending their time. And basically what we find is that both of them, men and women, were spending more time on unpaid work, and men were spending it on unpaid work on farms and basically tending the family business, whereas women were spending their time on domestic work. And the reason was that often they had migrant workers who had come back, so they were taking care of them. Their children were also back home, so they were taking care of them. So basically, both men and women were saying that, they spent more time in terms of childcare. Women disproportionately spent more time on childcare. And so they didn't have extra time in either case. And one more thing is the reason why men had more time was because, they had lost jobs in many cases. And because this was rural, they were often coming back. One topic we haven't covered, and actually, I don't have too much data on either, is migrant women, right? And migrant workers. We do have, like, of the households that we surveyed, about 20% of households reported a returning migrant. So that's a high proportion. And basically we find that these households and these individuals, suffered significant losses. And these, even in November, so this is, a pandemic that started in March, and by November, 3 times, migrant workers were 3 times more likely to be still unemployed than those who were already in that household. So, in terms of unemployment and job, like wage loss, it was a big hit. But I don't think any of us, or I haven't seen too many studies on migrant women. And I think that's an important topic that, could be looked at more deeply.
That's true, Divya. Sapna, did you want to add anything about women's caregiving responsibilities and how that's affected, the increase in caregiving responsibilities has affected other aspects of a woman's life and her health?
Sure. I mean, again, if we look at baseline low levels of labor force participation, the role, of course, of the supply of jobs in the market, we know there's increased evidence on that, but also women's caregiving responsibilities and household responsibilities are also a barrier to labor force participation, and the lack of things like creches, for example. So that said, I think the pandemic again brought out the increased stress as well. I mean, there's some emerging evidence on the mental health effects of the lockdown, both in India as well as in other settings, where we're seeing that we don't know probably enough, again, on the mental health effects on women. There have been some very interesting smaller studies around the country, though. So I think it's important when we think of the increased responsibilities that people were because other systems were not in place. There's also the effect on mental health, as well as her ability to take care of the other social determinants that determine well-being, so eating, being able to access basic services. And also, interestingly, something that came out in some of the qualitative work going back to self-help groups is that space and that ability to interact with others and those networks and how much they mean for one's own mental support and sort of well-being on a positive note, happiness, right? So I think the ability to access those and to remember that these are also really important for long-term resilience. When we think of a holistic picture of women's health, looking at the social determinants of both physical and mental health, it's not just access to services, it's the preventive, the promotive, but also things that support women, like these social networks. That really came out strongly in our work with SEVA, at least. Women used the phone, the ones who had access to phones, and this again varied a lot between the urban and rural members, but they found that, being able to do these group phone calls where they would do these group sessions, for 3 or 4 days in a row for an hour, for example, were really important, not just as a means to transmit information. We often think of these as platforms that are these static platforms that you can, shove information out to women, but they're also really important for them to be interacting with each other, identifying their own issues, and also finding their own solutions together. And that really came out strongly. So the caregiving, I would say, if we think of it on the flip side, is think about the mental health effects, as well as what can support longer term resilience as we move ahead, which we're all trying to do.
Right. And bringing this back also to Divya's point about the subpopulations that might be more ignored. So the migrant workers is one such community that seems to have been hugely affected, but we don't yet know the exact effects, I think, on them yet, especially even locally or at the national level. Are there other such subgroups, particularly maybe women of certain religions, certain castes, certain states that we find are worse performing than others in terms of their health outcomes and or employment outcomes?
No, I just want to kind of add a caveat for, I'm hoping for all of us here in terms of phone surveys, right? Phone surveys by definition are able to access particular populations who have phones. And then on top of that, and I can give you some numbers on that, but apart from that, we've done some investigation into this, and especially for women, even if household access to a phone is pretty high nowadays, it's in the 90%. The NFHS also asked a question on asked women, do you use the phone? So one is, does the household have a phone? That was in the 90%. Do you use the phone? The numbers then fall to around 40+%. So there's this huge drop off to start with. And similarly, then we asked the question is, what do you use the phone for? And 1/3 of the women that we interviewed said it was only for emergency purposes. So these were, of the women that we access. So, I would just say that there's a lot of bias in terms of who you're able to access, we are able to correct for it in some cases, or to some extent, because, for example, in our case, we had actually collected the phone numbers in person. So, we had done a proper sampling strategy in terms of collecting the phone numbers a priori before the pandemic hit. And so we have a sense of who's missing. And Suhani, as you mentioned, the people who are missing are the poorer households of, like minority households and scheduled caste households, etc. So definitely, that's something to keep in mind. The interesting thing, and just to kind of give a counterfactual also, is that we did look at then across these categories, what's the phone use like? And what we found is actually once they had the phone, then there wasn't much difference in phone use across these categories. So in fact, the gender dimension was stronger. It was, these other categories were not the kind of determining phone use. And finally, in terms of even the questions, because you were asking beneath on like sexual and reproductive health, right? Because it was a phone survey, in many cases, we had to kind of be careful about the kinds of questions we were able to ask. And so, for example, on violence against women or interpersonal violence, that was a topic that actually I think Sapna and I have also discussed about, whether we should collect it on the phone. And there's a lot of there are pros and cons, because the con is that you don't have this data if you don't collect it. But then the pro of not collecting it is that, you're not putting the respondent at risk, because you don't know what their context is like. And there's a lot of evidence showing that a lot of phone surveys are conducted with the speakerphone on. And so women often don't have the privacy to be able to answer, sensitive questions, let alone, any other question. So I would say just all our phone surveys should be taken with a bit of a grain of salt. And we've all tried to kind of do the best we can, but there are still, biases, and there are a lot of topics that we're not able to cover given those constraints.
Ronnie, could I come in?
Yes,
could I come in on that? So I think you're right, Divya, with the limitations of phone surveys. And I think something we also learned, and it was interesting, we did this implementation research study with SEVA when they started a mobile phone-based response, because the immediate response, of course, to reach women in groups was the phone. And knowing that women, and not all women had access to their own phone that they could use for these purposes, who were you leaving out? So I think they were initially quite hesitant, and were pleasantly surprised to see that you could use the phone to a larger extent than expected to do things even like group meetings. But in the long run, that these can only be really hybrid strategies to reach the most vulnerable. And it's really important to remember that there was great excitement around mobile phone-based responses, and it's certainly there and they were used, but who you're leaving out. And of course, that one-to-one interaction, we know from evidence of what works in terms of health and health information, is that it's those interactions that really matter. So just to also take with a grain of salt the idea of public health programming, becoming overly focused on mobile phone, and really remembering who we're leaving out, but also the delivery of how we're addressing people's needs and identifying services.
Completely agree. I think, Vineet, did you want to add anything? Yes.
Yeah, no, I think on these points around limitation of the phone service definitely echo. What I definitely resonate. My apologies. I think, but what we saw within our data set was also that historically vulnerable groups of women, right? So, for example, rural women or Muslim, migrant women, single, separated, widow, diverse women segments were worse off on almost all dimensions, right? So, for example, the key statistics that I do remember is that when you look at just access to food or food insecurity, almost 20% more single, separated, divorced women reported food insecurity as compared to on average, right? And then when you look at, again, and this is exceedingly worrying, because when you look at sort of the PDS system or the One Nation, One Ration card system, it's also very hard for these exact groups to actually be included, right? So I would definitely say that even within the populations that we are able to cover, there are segments that are which are historically vulnerable are worse off, and worse is that there are many segments which we are just completely in the dark because we're not able to reach them.
Yeah, and that's always a question as to then how do we do that? And I think post-COVID now, once things open up, I think there's probably a huge scope for research to be done with these people that were probably left out in in-person surveys, trying to understand how they're really affected. And I think that the role, and this might not really have been covered by the surveys, but I had this question around the public institutions that are currently able to reach these people who are not necessarily connected with technology at the moment. This could be like police stations, and a lot of the, especially in urban slum areas where police officers are reaching people in ways that really haven't been before. In rural areas, other than ASHA workers as well, I think the role that the panchayats play and people that can even reach out at the governance level as well. Have you found any insights as to whether these institutions have really been effective in supporting these populations around this time, or we just don't have enough data to comment on that? Yeah.
I think it's an definitely interesting thought, and I wish we had more data around the support that police stations or local panchayats or these entities give. But one channel that we definitely find has been very helpful, and we think can potentially, and if we're very at Dalberg, we're quite gung-ho about is just the PDS distribution network. Like that's probably the one that has the most reach across the country, and almost every household is able to actually benefit from that. So some of our recommendations that we, for example, wanted to test were also, for instance, can we actually bundle sanitary napkins or through and distribute those through PDS networks, for instance. So I would say I would be quite gung-ho about the PDS networks and its ability to actually support women. The other ones definitely, as Sapna talked a lot about, is SHGs, but that's something that we all know about.
Yeah, and I think I'm getting messages that we should move on to audience Q&A, but before we go to that, final question, and I'd love to hear all three of you talk a little bit about this in terms of the solutions. So as we're trying to build this long-term infrastructure, this resilient system, that whether such a calamity ever happens again, that we still are prepared for it, or in ways we are not going in the reverse direction again. How do you suggest how we try to somehow balance these long-term investments in health for women, say in India, with the short-term immediate response needs that a lot of these types of situations often demand of the government? So are there certain solutions or approaches that you've found that have worked beyond the schemes that we've mentioned here with the PDS or Manrega that the government has implemented that would really help in building a more resilient system going forward?
I can start, and I'll be quick. I think a lot of this lays actually in the public health and the primary healthcare response, that a resilient primary healthcare system that's also collecting data and that's, really able to respond locally to needs. And I think, again, the need for a nationwide lockdown was questioned from the point of view of, different epidemiologic needs in different places at different points, and the ability to respond with a really strong epidemic response and a public health driven response. When I think about supporting women's health and supporting women's health through the life course, it really goes back down to the core principles of primary healthcare. And I think this really highlighted and underscored the need to reconsider how we think about women's health, both the social determinants like employment and access to basic services, as well as what women's needs are over the life course. And I think our start is really in the health and wellness centers and expanding the packages of services that are available, and really supplementing and buttressing that with a strong data system. And I think, these surveys serve to remind us of how little information we do have and how much more we need in order to tailor localized responses. So I actually think the surveys and the constant, analysis and collection of some of these trends is what we need much more of to understand localized needs. rather than this one-size-fits-all approach.
I can go next. I think, what this pandemic has done is to kind of highlight like basically supply and demand side issues in a way in terms of public health. So from the supply side, India currently spends, as most of us might know, about 1% of its GDP on health, the government of India. And that is one of the lowest in the world. And so given that, I think just like increasing and not being shy of spending more on health is important. Basically, I agree with Sapna that you need to invest in primary healthcare, preventive care, but also curative care. I mean, I think at all levels, we need to strengthen our systems. And I would make a plug for universal healthcare. Because that's something that is missing, and it's really kind of important in the India context. I think even and going back to the health spending, given the low level, I think there's a lot of room for improvement in terms of expenditure. On the demand side, and again on the supply side, as we talked, using frontline workers, empowering them, and all of that is also very important. And it's a big topic. On the demand side, especially for women, I think it's very important to talk about social norms and just kind of getting women to, as against Suhani, you were talking about, understanding their rights and understanding that they, how to access healthcare services and preventive, curative, all of it. I think it's very important, and just kind of giving them the sense of entitlement. And there have been I think there have been some good work in terms of how to address social norms. It's a complicated, question. How do you do it? And there has been some good work around it, but I would say that that's important.
Right. And finally, Vineet.
Yeah, I think I fully agree with the point around data, sort of investing further into healthcare and so on. I think I would like to add maybe sort of two recommendations. I think that on top of my own. I think one thing that we have seen in our work, in this work as well as on the previous work that we have done on entitlements during this period, is that cash transfers have really, really helped, at least in the short term, to families. So I think, and we have a very effective rail that actually reaches a very large fraction of low-income households. So I think cash transfer and support like that should definitely continue. And I think it's important to actually cushion some of the shocks that these families experience. And I think the other one is more systemic. I think one of the things that we struggled with when we were trying to think of okay, so we've learned all about this, we had this learning agenda, how do we actually take this forward? A lot of the recommendations that we could think of, or the data, for instance, was throwing us was more about the here and now, right? As in, wasn't really actually changing the system that's actually causing this. And while we do feel that there is some level of, and I think the other bit that we saw was that the government systems would remain a primary player, right, when actually reaching and supporting women, given just the massive scale at which they operate. So we feel that we need to be really, really gender intentional in how we actually design some of these policies. And a lot of the building blocks are there, right? As in, we have a action plan. All government departments and ministries are supposed to take a gender lens and do gender budgeting, for example, right? But the way and the approach in which they actually look at what they consider as women's issues is sometimes just too narrow or sometimes too superficial, right? And I think those type of systemic changes, if we can make and actually drive gender intentionality in, I think, government programs, I think that would be quite catalytic.
That's actually a great set of very specific recommendations that I think three of you have spoken about. And I think we'll just take one audience question that comes from Minakshi. It ends on a positive note, which is, has there really been any positive social changes that have come as a consequence of COVID-19? Often when there are big crises like the Bhuj earthquake, often NGOs with vision are able to bring key social changes that would never have been possible in normal times. For instance, rehabilitation housing that considerably remove the caste barriers in assigning housing. So are there any such positive findings that we've had as effects of COVID? From the Dalberg study, from ID Insight. Yeah, Sapna, go ahead.
To start with one example, I had actually started tracking a program that Seva had been running before COVID and through COVID, which are these local women-run resource centers called Seva Shakti Kendras, and they provide a sort of one-stop resource for women to access, women and their families to access benefits, access health services, etc. And there are linkages really between families and the government programs. And what you saw was that these really sprung into action and completely were flexible and adaptable because they were local. And I think what we saw as a positive was that these are the types of programs and resources that people need close to them, that are flexible, adaptable, and completely context specific. And I think this really brought out, and I think we've all been saying the same thing, it highlights the need to be able to have those responsive services close to the ground. And we have seen great examples of it, of women coming together in groups and building resilience together in different ways. And that's the most important one, that variety and diversity of what is needed.
I think the one that stands out, it's quite hard, first of all, actually to figure out like what have been the positives. So, but I think the one that I can potentially think of is, and we are seeing this across many different sectors, that digital is now playing a more and more important role, and we are seeing a lot of uptake overall amongst many different communities. And it's a double-edged sword in many ways, because digital can also be exclusionary, as sort of Divya was pointing out, in terms of use amongst women. So I think if we are careful about how we actually design interventions through the use of phones and technology in general, I think that could potentially be a game changer. It's definitely accelerated adoption of many different services in agriculture, financial services, healthcare, education, and across. We just need to be, I think, smart about making those solutions inclusive.
Yeah, I think it's a tough question because, it's just been so difficult in terms of looking at these surveys and the effects of on lives and livelihoods. I mean, what has been heartening to see is some kind of, like, as I said, a bounce back over time, but it's still, we're still catching up in many cases back to pre-COVID levels. So I'm a little bit, pessimistic in that way. I would say that we actually have been analyzing HMIS data. And what that is also showing is that, the resilience, there is a resilience in the system. Even if you look at vaccinations today, right? Like vaccinations are finally taken off and really, like we're doing, well compared to where we were just a few months ago. And so from that perspective, I feel that maybe that confidence, like as I mentioned, PDS, the fact that it's reaching 90%, even like very quickly, we were able to reach 90%, as Vineet was saying, it really gives us a sense of hopefully our muscle that India can deliver if we, where there's a will in many cases. And I think that hopefully that confidence, helps in terms of then planning and implementing and, really reaching where we want to. So basically, like, I think leveraging some of these existing platforms and hopefully building back better. I think that is hopefully the mantra here.
I love that mantra. And I think that it really points to, in this conversation, we started off talking about the extent of the problem being worse than we expected when it comes to job loss for women, even the health effects of the pandemic. And then we did speak about food security issues and disparities within the household. Divya, that was very interesting when we're looking at both men and women in the same household and how the disparities even there. And then we see disparities across states, across migrant workers versus non-migrant workers, those that have access to technology and those that have really been left out because of lack of access to technology, those that are married and maybe having higher caregiving responsibilities, those at the front line who may have benefited or have been worsened because of the stigma associated with the pandemic and associated with them and their duties. And then we spoke about the lack of access to products, specifically menstrual health products or other women's health related products that normally women would feel shy to ask about publicly or ask about their health to health providers that are also missing and even fewer to access during the pandemic. So I think this was a great conversation. We probably learned, I learned a lot. I think hopefully the audience did as well. And that we are hopeful, pessimistic, but also hopeful that I think going forward, there are so many different solutions and that India can do it, and we can do it if we really put all of our energies together and are really trying to work together in filling all the gaps in the knowledge and the research that we have to be able to make informed decisions. So really, thank you so much for this great discussion, Sapna, Vineet, and Divya. And I hope that we can continue doing further research and filling the gaps. Thanks so much, Asia Society, the India Center, and Dalberg for convening this conversation, and really good evening to all the participants. Would love to hear from you. I'm sure all of us would love to hear. If you have any further questions, you can feel free to contact us. Thank you so much.